CLINICO profile of therapeutic keratoplasty at Tertiary Care Center, Hyderabad. Dr. Mauktika.
Good morning everyone. I am Dr. Kondapalli Mauktika, final year postgraduate from Sarojini Devi Eye Hospital. My topic of presentation is clinico-etiological profile of therapeutic keratoplasty at Tertiary Eye Care Center, Hyderabad. As we all know, therapeutic keratoplasty refers to replacing a deceased corneal tissue with that of a healthy donor tissue just to remove the deceased focus. TKP is routinely performed in developing countries like India, where monoocular corneal blindness is a silent epidemic, particularly in the working age group of 0 to 49 years of age. Infectious keratitis is the most common indication of TKP. In infectious keratitis, fungal keratitis is more common. The two most common fungi responsible for fungal keratitis in South India are Fusarium followed by Aspergillus. My purpose of the study is to present the clinico-etiological profile of therapeutic keratoplasty at Tertiary Eye Care Center in Hyderabad from September 2022 to March 2023 for a duration of 6 months. Objectives of the study is to indicate the indications of therapeutic keratoplasty. Materials and methods. The type of the study is hospital-based prospective observational study done for a duration of 6 months in the Department of Cornea and Trauma, Sarojini Devi Eye Hospital. Out of all patients presenting to cornea OPD, those who needed therapeutic keratoplasty were followed up with inpatient admission, comprehensive ophthalmological and microbiological examination, and postoperative resolution of infection. My sample size is 20. I included a brief chart that shows how we diagnose eye infections at Sarojini Devi Eye Hospital. The results are, out of 20 patients, 8 are females and 12 are males. The age range of the patients is 32 to 80 years with a mean age of 53 years. 17 patients were from rural background, 11 patients were agricultural laborers. These are the preoperative photos of the patients undergoing TKP. 5 had history of trauma to the eye with wooden stick, 3 had history of trauma with vegetative matter. History of diabetes, hypertension, asthma and rheumatoid arthritis are seen in the study subjects. 2 patients were actually using topical steroid drops that they procured from pharmacy without any consultation of doctors. 1 patient was using systemic steroids for rheumatoid arthritis prescribed by physician. Clinical presentation at admission, all are unilateral cases. Right eye is affected in 7 cases, left eye in 13 cases. Corneal perforation at admission is seen in 10 cases. Hypopyon in AC is seen in 8 cases. Secondary glaucoma in 2 cases. Microbiological analysis, out of 20 cases, 12 showed positive fungal growth, out of which 5 are Fusarium, 3 are Aspergillus, 2 is Penicillium, 1 is Curvularia and 1 is Bipolaris. These are the SDA medium showing the growth of the bacteria, fungi, KOH mount showing fungal elements, Aspergillus flavus, Aspergillus niger, Fusarium, Penicillium bipolaris highlighted by lactophenol cotton blue stain. Pseudomonas aeruginosa resistant to multi-drug is seen in 2 cases. Those 2 cases actually had a history of cataract surgery in the affected eye less than 1 month ago and they were diagnosed as postoperative endophthalmitis. They were first given intravitreal antibiotics and vitrectomy was done before proceeding to TKP. No organism could be isolated in other cases. This is a mechanism of isolating bacteria. These are the 20 cases showing demographic details, history, diagnosis and follow-up. Limitations of the study, it is small sample size, 20 is very small compared to thousands of TKPs undergoing in India every day. Postoperative follow-up was also not done. Double culture was not done in cases where no organism was isolated. Discussion. Non-resolving fungal keratitis, it is the most common indication of therapeutic keratoplasty accounting for 60% of cases of the study in par with the current studies. Males and young patients are particularly affected. Majority of the patients had rural background, low socioeconomic status and agriculture as their predominant occupation. One of the interesting findings we found in our study are, though the incidence of Fusarium keratitis is far more than that of Aspergillus in South India, like 60 to 40 ratio, the cure rate for natamycin and Fusarium keratitis is more and hence the percentage of Fusarium keratitis actually ending up in TKP are far less when compared to that of Aspergillus keratitis. This is actually my thesis topic. My 1 year sample size was 68, out of which 54 showed fungal positive, 28 out of 54 were Aspergillus positive and only 16 showed Fusarium positive. This discrepancy could be because of natamycin being less penetrative than other antifungals and cure rates of natamycin is more for Fusarium when compared to Aspergillus and Aspergillus being a more invasive disease. Further research need to be done to prove this. Finally, fungal keratitis is the most common indication for therapeutic keratoplasty. These are my references. Thank you.
Right. Thank you, Moktika.
Thank you.
So since you had a study on penetrating keratoplasty,
Yes, ma'am.
did you subject the corneal buttons that you had
Yes, ma'am.
excised?
Yes, ma'am.
Did
We
you
subjected the
them
corneal buttons, ma'am.
to?
The samples sent were initially before TKP, we sent the corneal scrapings, ma'am. And then intraoperatively, we sent, if any exudates in the AC, we sent those samples. And corneal button also was sent, ma'am.
So was
And
there a
I
correlation between pre and post?
Ma'am, generally most of the cases pre-operatively only we got the diagnosis, ma'am.
So out of 20, how many were positive microbiologically?
Of 14.
14. And in the rest of the 6, did
No
you get
organisms
anything?
could be isolated, ma'am.
Even on the corneal button?
No, ma'am, no.
Do
Even
you
on
also,
corneal button.
Do you also subject them to histopathology?
Yes, ma'am.
So half of the corneal button is sent for histopathology?
Histopathology and yes,
half
ma'am.
to,
Yes, ma'am. Yes, ma'am.
That was also not
Not
conclusive.
ma'am.
Okay, thank you. I think you
Okay.
can mention
6.
that also.
Okay, ma'am.
One-
6 cases were actually no organisms could be isolated, ma'am, even after surgery.
One most important conclusion of your study was that the most of the people with aspergillus infection, they'll end up
Yes,
more
sir.
than the
Yes, sir, fusarium.
Okay, that's
the
a message
first
to
thing.
the
Yes, sir. The
That's a-
first thing is it is a government setup, and we mostly use natamycin, sir.
Thank
And
you.
availability of auriculozoles is not there.
There are multiple reasons for that.
Yes, sir.
Yes.
So aspergillus ending
Thank you.
case, sir, most.